Good afternoon, everyone. pCoE JNIMS Manipur welcomes all the participants for today's RDLS session. Today's topic is immunization among CLHIV, and the speaker is Dr. N. Kameshore Singh. Dr. N. Kameshore Singh, sir, is currently the professor and the head of pediatrics and the program director at the Pediatric Center of Excellence in HIV Care at JNIMS Imphal. With over 2 decades in the state health service as a pediatrician, he is a distinguished recipient of the Pioneer Award from the East Zone Academy of Pediatrics. He has extensive experience in HIV/AIDS, having attended numerous NACO, WHO, and UNICEF trainings. He held key positions in the Indian Academy of Pediatrics, Manipur State, and the East Zone Academy of Pediatrics. He has published numerous papers in national and international journals. Additionally, he has presented his work at various state, zonal, national, and international conferences. We welcome you, sir, for today's session and request you to start the session.
Thank you, Sweta. So, very good afternoon. Today we'll have a discussion regarding the immunization in children living with HIV. So, can we start the slides, please, Sweta? So, the objectives of today's RDLS, that is immunization in children living with HIV. We have to see what are the key milestones in the UIP in relation to India and the importance of immunization among children living with HIV. We should see what is immunity and the types of immunity in the form of active and passive immunity, vaccinations, and what are the types of vaccines used in children. And at the same time, we will see immunization and the effect of HIV infection, vaccine safety, and the risk of disease with live vaccines in children living with HIV, and what is national immunization schedule. And at the end, we'll see the key points of immunization in CLHIV. Next. So let us see what is immunization. Immunization is a very good proven tool for control and eradication of infectious diseases and the most cost-effective measure to reduce childhood morbidity and mortality. So we have Universal Immunization Program UIP in India, and but we don't have a formal guidelines for children living with HIV. And the Indian Academy of Pediatrics has established guidelines for vaccinating children with HIV infections. CDC, ACIV, WHO recommended immunization guidelines for HIV infected children. Next. So this is the key milestones regarding Universal Immunization Program in India. UIP was initiated in 1985, and we have a long way since then, and we add hepatitis B in 2001, and like that we have started adding measles second dose and inactivated polio vaccine in 2012. Like that, we have a long way, and in between also we have started investigating and assessing the adverse events following immunization so that we can improve our vaccine coverage, the side effects and events associated with immunization, and the various corrective measures to decrease these AFI as well as to improve the compliance and to decrease the dropout in immunization of normal children as well as children with living with HIV/AIDS. Next. So let us see how important is immunization among children living with HIV. We know that HIV infected children are more susceptible to diseases because of their decreased immunity, and this particularly in infectious diseases, and more likely to develop severe complications in comparison to immunocompetence syndrome. And therefore, there is an increased need for vaccination against all vaccine preventable diseases. And it is important to ensure that they receive all recommended immunizations against vaccine preventable diseases. Now in the UIP, we are having 12 vaccine preventable diseases. ICIV disease progress very rapidly in young children, and it may often lead to death. Therefore, the counselor should inform the caregiver when the next immunization is needed, and should review immunization record to identify any misimmunization and arrange to redress these misimmunizations as soon as possible. Next. So let us see how we can do vaccination in children living with HIV. The majority of the children born to women who are infected with HIV do not acquire HIV infection. It is only 30 to 40%. And of those children who do become infected also, most acquire the virus from their mothers at the time of delivery and shortly thereafter. Therefore, early in life, they are immunologically, most of the children are normal, or if at all, if there is decrease, the decrease is usually immunosuppression is usually minimal. And when most of the primary series of vaccines, which is either started or completed, because we start from birth only. So next. So if we see what is immunity, we can group them into innate immunity and adaptive immunity. So innate immunity comprises of the skin, mucosal barriers, phagocytes, particularly neutrophils, monocytes, macrophages, and the natural killer cells. And adaptive immunity is provided by lymphocytes. Those are T and B cell lymphocytes. The innate immune system triggers the development of adaptive immunity, and the important function of them is by presenting the antigens to either B or T lymphocytes. And when we use vaccines, these vaccines stimulate innate immunity, are better immunogens. So they are better immunogens. Next. So this is the pictorial, this representation of active and passive immunity. So active immunity is achieved when we have an exposure to a pathogen which triggers antibody production, which can be natural infection triggering antibody production, or artificial by injecting vaccines. So in this active immunity, resistance develops in response to the stimulus by an antigen, which may be infective agent or vaccine, and is characterized by the production of antibody by the host. In case of the passive immunity, it can be natural, where in this passive immunity, a person is given antibody rather than producing this antibody by themselves. So it can be natural, for example, maternal antibody from mother to child in the breastfeeding, because breastfeeding, breast milk contains various types of living cells and immunoglobulins, and it can be artificial by giving monoclonal antibodies. So this passive immunity is conferred by an antibody which is produced in another host, and it may be acquired naturally through breast milk or artificially trained antibody containing preparation available commercially. Next. So immunizing agents, we can summarize consisting of the vaccines, immunoglobulins, and ready-made anti-serum. Next. So if we see vaccination, so it is a method of giving antigens to stimulate the immune response through active immunization by the recipient. And a vaccine is an immunobiological substance which is designed to produce specific protection against a particular disease. And a vaccine is antigenic, but not pathogenic. So it is usually done by subcultures, and we can say this is attenuated vaccines. So let us see what are the types of vaccines available for use in children. So we have live attenuated vaccines, for example, bivalent oral polio vaccines, Bacillus calmette-guerin BCG vaccines, MR measles rubella, and MMR measles mumps rubella vaccines. Kill vaccines may be of inactivated type in the form of toxins and the toxoids. It can be kill vaccines or maybe subunits. And another group of vaccines are whole cell inactivated vaccines like pertussis, rabies, inactivated polio vaccine, and hepatitis A vaccines. And toxoids are diphtheria and tetanus toxoids. Subunit vaccines contains only antigenic part, and the protein vaccines can be, examples are acellular pertussis, hepatitis B vaccines, some influenza vaccines. We have pure polysaccharide vaccines, typhoid vaccines, and these pneumococcal polysaccharide vaccines, meningococcal polysaccharide vaccines. We have also conjugated polysaccharide vaccines. Examples are typhoid conjugate vaccines and Haemophilus influenzae conjugate vaccines. Live virus live particles, an example is human papillomavirus vaccine. And we also have COVID vaccines, COVID-19 vaccine in the form of DNA and RNA vaccines. Next. So when we see immunoglobulins and anti-serum, human normal immunoglobulins available are of hepatitis A, measles, rabies, tetanus, and mumps. And specific immunoglobulins, human specific immunoglobulins are available against hepatitis B, chickenpox, and diphtheria, and non-human anti-sera also available for diphtheria, tetanus, gas gangrene, botulinum, and rabies. Next. So let us see immunization and effect of HIV infections. The majority of the children born to women who are infected with HIV do not acquire HIV, which I have mentioned already. Of those children who do become infected, most acquire the virus from their mother at the time of delivery and solely thereafter. So early in life, they are immunologically normal. And if immunosuppression, if there will be usually minimal, and when most of the primary series of vaccines are either started or completed. These three sentences indicates that there is always have the chance to give these vaccines in children who are born to HIV-infected mothers. So HIV-infected children develop immune dysfunction, affecting all aspects of immune system with increasing age. And therefore, immune suppression results in increased risk of severe disease from vaccine preventable infections. and affects the quantity, quality, and persistence of protective immune responses to natural infections or vaccination. This indicates that immunization is more important and more so required in children living with HIV. Next. So that's why let us see the following areas of concern which are critical to the children living with HIV. And the question is, will the effectiveness of a vaccine be impaired because of the underlying immune deficiency in CLHIV? Are children receiving a live viral vaccine or bacterial vaccine subject to a significantly increased risk compared with non-infected persons? And does administering a vaccine significantly affect the rate of HIV-associated disease? And these are the concerns and the questions which may arise in children living with HIV. Next. So these emerging areas of concern, let us see, impaired seroconversion on clinical efficacy. So because of their immune mechanism being affected, they may have impaired seroconversion and leading to impaired clinical efficacy. Therefore, there may be need for increased amount and or number of doses required for these vaccines. And we have to see the safety issues which is associated with live vaccines. And there is always chance of decreased duration of protective efficacy of these vaccines in CLHIV. And we have to see, is there any effect of vaccine on the rate of HIV progression? These are the areas of concern which we have to critically analyze in children living with HIV when we plan immunization. Next. So when mother is also HIV infected, the mother itself is immunodeficient. So does not have protective antibody against infections. And those babies who are pregnant with or developing intrauterine in these mothers may have poor transplacental acquisition of antibodies to the babies, and the susceptibility to infection at early age may be increased as mother may get infected with vaccine preventable diseases and exposing the child to these vaccine preventable diseases. So the mother is infected and the baby is also likely to be infected, and the less chance of antibody being transferred to the babies. Next. So let us see the vaccine safety and the risks of disease with live vaccines in this CLHIV. Next. So safety of the vaccines in CLHIV. And in general, as we have discussed earlier also, because of the less chance of transmission, because of the starting of the immunization in the early age when they are particularly immunologically normal or less also minimal, then therefore immunization is generally safe and beneficial for children living with HIV. Although HIV-induced immune suppression reduces the benefit compared with that obtained in HIV-uninfected children. Unless the child has rapidly progressing HIV-related disease with severe immunocompromised condition, usual routine vaccinations should be offered according to the age as early as possible. Next. So non-replicating vaccines are not associated with increased risks of complications, so they can be safely given. BCG, measles, oral polio, and yellow fever vaccines have been reported to be associated with complications, particularly in severely depressed immunity. Next. Immune suppression in HIV-exposed babies usually takes several months to develop. So, administration of BCG to HIV-infected children in the first few months or in the first few days is associated with low rates of complication. So, idea is that we can give BCG at birth in these children, and the progressive immune suppression can also lead to the reactivation of latent BCG organisms. So BCG should be considered at birth. And let us see what are the possible complications of BCG in children living with HIV. It may produce regional, extra-regional, localized or disseminated BCG disease, which is really happening. It may occur regional lymphadenitis, and sometimes it may produce poorly healing ulcers and fistula. Next. So, therefore, live vaccines not to be used in CLHIV if the CD4 count is less than 14% or 200 per cubic millimeter. And these live vaccines are particularly MMR, chickenpox vaccine, and the yellow fever vaccines. For BCG, we have already mentioned live vaccines not to be used if safer inactivated alternative exists, and also not to be used in close contexts. Live intranasal influenza and oral poliomyelitis vaccines to be used with caution. And if there is alternative vaccines available, then we have to use that. For example, for polio, we have inactivated polio vaccines. And for influenza also, we have inactivated influenza vaccines. And BCGs should not be used in low endemicity countries. Although rates of adenitis substantially reduced by early initiation of ART. But in India, as there is high endemicity, we have to use BCG vaccines. Next. So let us see what are the adverse events following immunization. And AFI, it is defined as any untoward medical occurrence which follows immunization and which does not necessarily have causal relationship with the use of the vaccine. So it is any event which is associated with immunization, not necessarily may be associated with the vaccine itself. So we can group this AFI into 5. First group is vaccine product related reactions. Second, vaccine quality defect related AFI. Third, immunization error related AFI. And immunization anxiety related AFI and coincidental events. So while investigating AFI, we should see what could be the cause of this AFI among these 5 probable conditions. And the IAP has given its guideline on immunization in 2018-2019 as 3rd edition. Next. So let us see what is the national immunization schedule which is presently available. So now at birth we have BCG which is given in the dose of 0.05 up to 1 month, and of course the vaccine can be given up to 1 year, but in case of the CLHIV newborns, exposed newborns, we can give at birth as early as possible. We have 0-dose oral bivalent polio vaccine, and we have hepatitis B bar dose, which is to be given within 24 hours of birth. At 6, 10, 14 weeks, we have 3 primary doses of OPV 1, 2, 3, rotavirus vaccine 1, 2, 3, in fractionant inactivated polio vaccine 1, and the second at 14 weeks, we have pentavalent 1, 2, 3, and we have pneumococcal conjugate vaccine 1 and 3 at 6 and 14 weeks respectively. At 9 to 12 months, we have MR1, Japanese encephalitis first dose, PCB third dose, which is taken as booster, and nowadays we already added fractionant IPV third dose, which is taken as in booster in between 9 to 12 months, which is missing here. And in 16, 24 months, we have MR second dose, DPT first booster, and a booster of oral polio vaccine, JE second dose, along with vitamin A in first started in 9, 12 months, and the second in 16, 24 months. At 5 and 6 years, we have second booster of DPT. At 10 years, we have tetanus and low dose diphtheria. At 16 years, we have TD, small d, and in pregnant women also we have tetanus and small d, and 2 doses or booster is applicable. Next. And the vitamin A is given every 6 months up to 5 years, total of 9 doses. Next. So let us see what are the desirable vaccines, whether it is available in the national immunization or not, particularly those who are not available in the national immunization schedule. So we don't have inactivated hepatitis A vaccine in the national immunization, and it is to be given 2 doses 6 months apart between 12 to 23 months. And we can give inactivated influenza vaccine, which can be started from 6 months, and we give 2 doses after our second dose after 1 month, and we can give every year up to 8 to 9 if started within 8 to 9 years, and otherwise we can give single dose every year in those children above 8 or 9 years. We have chickenpox vaccine, which is administered the first dose at the age of 15-18 months, and the second dose is given at 4 to 6 years or earlier when it is required to finish the second dose earlier. Since this is a live attenuated vaccine, it is given only to asymptomatic children and who are not severely immunocompromised if we consider the children CLHIV. A single dose of HIV is indicated in unimmunized children more than 5 years of age, those who do not complete the primary series, and the 15-month booster of HIV not given earlier. So single dose of HIV can be given, and meningococcal conjugate vaccine should be administered 2 doses at least 8 weeks apart between 9 to 23 months of age, and a booster may be considered after 2 to 5 years. I used to give after 5 years after the primary series. The 3-dose series of human papilloma virus. So human papilloma virus, we give 2 doses if we start between 9 to 11 months, which is the best time for human papilloma virus, and it can be considered up to 15 years. Beyond that, we used to give 3 doses at 0, 1, and 6 months. And the tetanus toxoid can be considered reduced diphtheria toxoid as cellular pertussis. Tdap vaccines may be considered. So these are vaccines which may be considered in ICIV, not available in the NI, National Immunization Schedule. Next. So let us remember some key points. So ICIV exposed infants, like all other infants, they should be given BCG at birth. Because at birth, we have already discussed, they are immunologically more or less normal. If BCG has not given at birth, or for neonates with ICIV infection confirmed by early virological testing, BCG vaccination may be delayed uh, uh, after starting ART, and the infant is confirmed to have immunologically stable. So we can always either give at birth or after starting ART in confirmed cases, so that the child is stable and immunologically improved and stable. For children who are receiving ART and have not received BCG earlier, it may be given once they are clinically well and immunologically stable, which I have already mentioned. And for children aged less than 5 years or CD4 count greater than equal to 200 cells per cubic millimeter, if aged more than 5 years, this is CD4 count. When it is normal, we can always give. Next. Severely immunocompromised ICIV infected infants, children, adolescents, and young adults, as defined above, should not receive live viruses, particularly measles virus containing vaccine, because vaccine-related pneumonias has been reported. WHO recommends that an additional dose of measles containing vaccine be administered to ICIV infected children receiving ART following immune reconstitution if CD4 count is normal, for example, more than 25%. A supplemental dose of measles containing vaccine may be considered in ICIV exposure infants or soon after diagnosis of ICIV infection in children older than 6 months who are not receiving ART. Usually we give measles vaccine at 9 months. Next. Rotavirus vaccine, though live vaccine, is recommended for use in CLHIV because ICIV exposed in infants, they are more vulnerable to diarrheal diseases. The vaccine virus is a highly attenuated virus, and immunization with the vaccine is, if given early in infancy, when diagnosis as an vaccine is not confirmed, in most infants, we can give this vaccine. Moreover, even those who are infected but not diagnosed yet are unlikely to have severe immune deficiencies. Therefore, we can give. Nevertheless, like all vaccines, it should not be given in children who are symptomatic and a non-severe immunodeficiency. Next. So, pneumococcal conjugate vaccines, which are given at 2, 4, 6, with booster at 12, 15 months, but in the UIP we give at 6, 14, and 9, 12 months. It is recommended that pneumococcal polysaccharide vaccines should be administered at least 8 weeks after the last dose of PCV to children with ICIV infection aged 2 years or older. And here I would like to remind all the participants that polysaccharide vaccines are given after completed 2 years. Inactivated Japanese encephalitis vaccine is safe for use in children with ICIV infection. And a live attenuated JE vaccine is also now made available, and this is as live vaccine. It is to be avoided in children with ICIV. It is desirable to check the seroconversion and give booster as required, especially for hepatitis B because these children are known to partial, that there may be marginal decrease in the vaccine tech. So a 4 dose, maybe sometimes double quantity, may be given in those poor conversion and with routine immunization. But we can always see the seroconversion by testing. Next. So to conclude, HIV infected infants and children can safely receive most childhood vaccines as per the national or state immunization programs, though the efficacy may vary. Oral polio and intranasal influenza vaccines are usually not given in HIV-infected patients, particularly those who are symptomatic and immunocompromised. BCG should be given at birth, but if not given at birth, and it may be delayed in symptomatic CLHIV until antiretroviral therapy has started and they are confirmed to be immunologically stable, which we are doing. Live vaccines avoided in severely immunocompromised CLHIV, particularly when CD4 count is less than 15%, and or if the child is symptomatic, child or children, we avoid live vaccines. Next. Rotavirus vaccines should be given in HIV-exposed infants due to their higher risks of diarrheal diseases, which we have already mentioned. Inactivated Japanese encephalitis vaccine is safe for use in CLHIV and it should be given. We can give additional booster as required, especially for hepatitis B and hepatitis A, and we can always check the seroconversion rate. Taking the advantages of immunization, we can always give vitamin A supplementation for prevention of vitamin A deficiency blindness, which is incorporated in the national immunization schedule. Desirable vaccines not available via the national immunization schedule, for example, inactivated hepatitis A, inactivated influenza vaccine, inactivated varicella vaccines, and pneumococcal conjugate vaccines can be given. But now pneumococcal conjugate vaccines are available as 6, 14 weeks, and 9, 12 months. Immunization status should be reviewed at every visit, and the response to vaccination may be evaluated whenever required. Next. So thank you so much for the patient hearing. And if any doubt or any query, any questions, I will be happy to answer.
Thank you so much, sir. Any questions from the participants? Mic access has been given to all. You can either unmute or you can put your questions in the chat box. So I don't think there are any questions. Thank you so much for facilitating this session.
Thank you
Thank
for
you, sir.
giving me the chance for this.
Thank you, sir. Thank you to all the participants for patient listening. We'll conclude the session now.
Yeah, some money.